Welcome back, everyone. We are officially at part 7 of our OBGYN Coding Explainer series, and today we're diving into a really critical, high-stakes area of ICD-10-CM Chapter 15, Labor and Delivery Complications. As we explore codes O60 through O77, we're going to use a sort of funnel of application approach. We'll start wide with the overarching rules of compliance and then gradually narrow our focus all the way down to a specific clinical scenario to see exactly how these codes work in the real world.
Okay, let's dive into this. Here's our roadmap to confidently navigate intrapartum clinical documentation. We'll kick things off with a labor and delivery overview, move right into dysfunctional labor and induction, explore obstructed labor and emergencies, and wrap it all up with a clinical case walkthrough.
Section 1, Labor and Delivery Overview, Setting the Foundational Rules. We absolutely have to start with the overarching compliance rules before looking at any specific complications.
And here it is. This is the absolute guardrail for coding this chapter. ICD-10-CM codes O60 through O70 are assigned strictly, and I mean only, during delivery encounters. You can't use these for routine prenatal visits, and they definitely aren't for high-risk supervision at, say, 24 weeks. They are literally reserved for when the patient is actually in the delivery encounter. So, to accurately assign these codes, you really have to think like a clinical detective. Your documentation essentials are pretty clear-cut but totally crucial. First, what is the exact type of complication? Second, the timing. Did this happen during labor, during delivery, or was it an anesthesia complication? Third, we have to pair that complication code with a Z3A code to capture the exact gestational age. And finally, you need to validate the delivery method, any interventions like a cesarean, and the delivery outcome pairing, so your O80 through O82 codes. Validating all these clinical details ensures your coding is absolutely bulletproof.
Section 2, Dysfunctional Labor and Induction, When Progress Stalls. Let's zoom into those distinct categories where labor just doesn't go exactly as planned.
Looking at the first two categories, O60 is what covers preterm labor, specifically O60.1 when spontaneous preterm labor actually results in a preterm delivery. But O61, that one is fascinatingly specific. It's used purely for a failed medical or surgical induction. The catch here is that the documentation must explicitly prove an induction was actually attempted and that it failed. If there's no documented attempt, you literally cannot use O61. Now, what's really interesting about this slide is how it contrasts the how versus the how long of dysfunctional labor. It creates a great mental filing cabinet for us. Category O62 is all about the forces of labor, so things like hypotonic uterine inertia, where contractions are just too weak, or hypertonic labor, where they're erratic. But category O63, that has absolutely nothing to do with the strength of the contractions. It's purely about duration. For example, if a provider explicitly notes a prolonged second stage lasting over 3 hours, that directs you perfectly right to O63. Section 3, Obstructed Labor and Emergencies, High-Stakes Coding. We are moving from dysfunctional labor straight into mechanical obstructions and intrapartum emergencies. Category O64 is reserved for obstructed labor that is specifically caused by malposition or malpresentation. We're talking about situations like a breech presentation or a transverse lie that is physically blocking the delivery process. And remember, there is a critical rule here. If you're dealing with multiple fetuses, O64 requires strict attention to the seventh character so you can identify exactly which fetus is causing the obstruction. Let's walk through this high-contrast emergency workflow card, because this really shows how specific maternal or fetal compromises translate directly to precise ICD-10-CM codes. Fetal shoulder impaction require maneuvers. That maps to shoulder dystocia, O66.5. A cord prolapse diagnosed during labor requiring an immediate cesarean? Boom, O77.0. You also want to notice the clinical nuance between O68.0 for fetal distress with non-reassuring heart rate patterns versus O76 for a specific fetal heart rate abnormality, like tachycardia, noted on a monitor. We even track maternal complications, right, like O75.82 for severe exhaustion leading to ineffective pushing. Every precise clinical term maps to a very distinct code. Section 4, Clinical Case Walkthrough, Applying the Rules. Our funnel has narrowed, and it's time for a hands-on, high-stakes clinical scenario to test exactly what we've just learned. Okay, here is our scenario. Let's look at this like auditors and solve the puzzle. A 29-year-old woman, gravida 2, para 1, is in active labor at 38 weeks gestation. A clinical exam reveals a transverse lie causing obstructed labor, and it requires a planned cesarean section. So, what do you think? Which code applies here?
So, the crucial point is that the safest way to the right answer is methodically eliminating the wrong ones. Step 1, we can easily rule out primary uterine inertia O60.0 because labor forces are definitely not the documented issue here. Step 2, we rule out prolonged first stage O63.0 because duration isn't the complication we're dealing with. And step 3, we can just immediately discard failed medical induction O60.0. Why? Because there was absolutely no induction attempted. She was already in active labor.
Which triumphantly brings us to the correct selection, O64.2, for obstructed labor due to transverse lie. This flawlessly captures both the mechanical obstruction and the specific malpresentation. And, tying it all the way back to our foundational rules from the very beginning, we pair this with Z3A.38 to capture the 38 weeks of gestation. This ensures your record is completely compliant and accurate.
Always remember, you code O60 through O77 categories strictly for delivery encounters, and you must always let the specific clinical documentation guide your path. As medical record systems become more and more automated, it really makes you wonder, will AI ever be able to decipher these incredibly intricate, high-stakes clinical nuances, or will the human detective always be required? It's something to think about. Thank you for watching, and stay tuned for Part 8. This is Decode Healthcare with Harshal.